Now, one of the other main causes of vision loss that is treatable, and it's probably the number one most successful surgery that's performed in the United States, is treatment of cataract. And what I tell everybody is, if you're over the age of 45 or 50, you have a cataract. Just the word cataract does not mean that you have to have surgery. The decision to have cataract surgery is based solely on how symptomatic you are. Are we able to make your vision better with glasses? Does it interfere with your daily activities? And the three things, the most common things I will hear from the patient are having difficulty driving at night. I don't like it as much, or I just avoid certain times. Maybe it's not necessarily glare, but some component of cataract can cause glare of lights. But otherwise it'll be, I can't see it tonight as well. I don't like to drive at night as well. I'm having trouble reading small print, or I need more light, and I can't see my golf ball. I hear that all the time. Like, I hit my golf ball and I lose it. Someone has to see. It's a measure of contrast, and so it's a really good measure of how well someone's seeing. If you hit a white ball up in the sky, can you see those subtle differences? And cataracts typically start to claim your contrast. The night vision is explained by, if you were to wear sunglasses when you're driving at night, you'd feel like you need a little more light to see. And I tell patients with cataracts, it's like driving at night with sunglasses on. You're limiting the amount of light that gets into your eye and then focuses on the retina. And so everybody becomes symptomatic at a different time. I've got patients in their 40s and 50s that need cataract surgery. I have patients in their 90s who are functioning well who don't need surgery. And it's always up to the patient to kind of make that determination how it's affecting their lifestyle.
That also handles some of the interests that I was going to pose to you, some of the questions. But when I come in for an annual eye check, I'm usually seen by someone who checks my eyes. Now, you mentioned this instrument, machine, or whatever that does it so you don't have to sit with a technician.
Right.
But now you get that information, you do, and you're going to see the patient. What are your thought processes at that point? You have the vision test, which has been done, I guess refraction, which
tells me what you're capable of seeing. Sure.
And whatever other information there is. You've got that. Now you go to see the patient, which is always you and the patient. Okay? And what's your thought process? How do you explain or deal with this very sophisticated equipment that you have? And what kind of information does it give you? What kind of information would you like it to give you?
Well, I mean, a typical exam, what we're going to use is the slit lamp, which is our microscope, and that's gives me a magnified view of every feature of your eye. And then I use lenses. Once your pupils are dilated, I can put a lens up in front and I can actually magnify the structures in the back of your eye. I can see your blood vessels, I can see your arteries and your veins, I can see your retinal health, I can look at your optic nerve. So I can pick up whether you've got high blood pressure, I can see typically signs of diabetes, arterial sclerosis. The eye exam truly can tell me about the health of your body. I mean, there's almost nothing that doesn't show up in the eye in one way or another. Systemic diseases, thyroid disease can show up with eye findings. Myasthenia gravis we diagnose, which is a neuromuscular condition we can diagnose with an eye exam a lot of times. A lot of the symptoms. That
condition is where you can't keep your eyes open?
A lot of it can be, but it's an overall muscle weakening condition that can be treated. It's an autoimmune condition, but a lot of times the first findings are typically eye related. It's really fascinating, but when they say the eye is the window to the soul, it truly is. And we know as the future comes and technology improves, artificial intelligence comes along, and we've learned a lot about artificial intelligence as we've been doing with GlobeCheck and dealing with a lot of these companies. There are amazing advances with diagnoses. I mean, you've heard, and there's been bits and pieces that will show up in the media periodically. Oh, you can diagnose Alzheimer's with an eye exam. Well, those things will be in the future, certainly. We'll be able to tell your cardiovascular risk factors based on looking at your retina. Do you have high cholesterol? Should you be treated? Are you at risk for heart attack or stroke? I mean, we see strokes in the eye, so many times we'll diagnose carotid artery disease by seeing a little plaque in one of the retinal arteries that you may or may not have symptoms from. We can see what's called a Hollenhorst plaque, and that's a little small piece of cholesterol that can lodge in a small peripheral artery in your retina. And when we see that, we've sent patients off who have avoided strokes and massive strokes by having the carotid arteries checked, and they had no idea they had any symptoms. Sometimes it'll be a heart valve issue that'll cause a piece of plaque or a piece of cholesterol or other types of plaque to break off and lodge in the retinal vessels, and we can see those things. So there's almost not a day that goes by that we don't pick up something that's related to someone's systemic health. We diagnose skin cancers all the time around the eyes. They show up quite frequently in the eyes.
Well, yeah, my dermatologist said to be sure to be careful about how much UV you get in your eyes. Always wear sunglasses. And he was speaking of skin cancer and cancer in the eye.
Sure.
So yeah, are any of these tests invasive?
Well, most of the tests we do in ophthalmology are not invasive. In fact, most of them don't even require touching of your eye. When we check pressure, we can do that with a non-contact pressure, which is a puff. Not typically as accurate, but we do that in certain instances. Or we have to just touch the surface of your eye, and we typically numb the eye to do that. But most of our tests are done just, cameras, lasers, ultrasounds, all of those things that don't really have to come into contact with the eye. In fact, GlobeCheck can do the eye exam without even dilating. We actually can take a picture of your retina, take a picture of your optic nerve, and map out your eye exam completely without dilation or touching of your eye, which has a lot of appeal.
Yes.
Nobody likes to be dilated. That's always
It's going back outside into the bright sunlight that's the problem. Once diagnoses have been determined, and you've just described that not only would you be diagnosing issues with the eye, but other issues as well. How do you get that information across to the patient? And hopefully you're going to give them some instructions on what they should do.
Sure.
Have you any way of making sure they do it?
Well, there's something called personal responsibility, but our job is to make sure that we translate and get across to a patient how important something that we're recommending is. Ultimately, it's, if we've done our job, it's someone's responsibility at home. If we give someone a treatment to do or an eye drop to do for glaucoma, if they choose not to take it, they have to understand the ramifications of that, and we do our best to monitor that. We're working on different ways to have a little bit closer interaction with patients. We're working on an app where if we give someone instructions, it would give them the feedback, a text message, or their phone would beep to them, you need to take your glaucoma drop at this time, and allow for that feedback. I'd like that interaction where if Mrs. Smith isn't taking her drops for 3 days, we get a text message to our office and says, you know what, you may want to follow up with Mrs. Smith, she's not taking her drops as directed. So having some of those things with technology will allow, I think, us to better monitor and communicate with our patients. But our job is to communicate. That's really what it is. It's about, patients believing they're here for my advice, they're here for our advice, and we're here to give it. So if we have a recommendation, if someone doesn't feel comfortable with that recommendation, they need to voice that and voice that with me, and then we can figure out what to do, whether it be, well, let's get a second opinion and see if that other person confers with that and agrees with that or doesn't. But ultimately we follow up with patients at appropriate intervals to make sure that the treatments that we're doing are hopefully being done and hopefully giving us the desired results.
That they're working.
Yeah.
Now, there's one group of patients that, as I remember from my youth, is that children are hard to work with when it comes to wearing glasses. Is there any movement, has anything happened to encourage students to do encourage children to realize that this is not an insult, and you're going to get teased?
Well, it's hard. Depending on the age, some kids want glasses and some kids don't. My kids wanted glasses early, and then once they didn't want them. But we try to transition kids into contact lenses if they're sensitive about the way things look. And some kids are good with contacts at a very early age, and some are not so good. Some of our adults are not good with contacts in terms of being responsible and taking care of them appropriately. So, contact lenses can lead to major problems, corneal ulcerations, and people try to wear them more than they should, or sleep in them, or do those kind of things. They put themselves at great risk. But we work on that. Sometimes it's a matter of permanent vision loss. If a child doesn't wear glasses, you can develop something called amblyopia, where you have if you have kids who either have crossed eyes or very unusual glasses prescriptions, and if they're uncorrected, typically in kids you're going to see an eye crossing or something where parents go say, hey, my child's eye's crossing. When we pick that up, if you don't straighten those out or get those corrected, you get a permanent loss of vision. the brain's remarkable in a child. So if you have one eye that doesn't see as well, the child's brain may actually choose to ignore that vision completely, and it doesn't develop the proper connection to the brain. And so if a child has an eye that turns in, and if that happens in an adult, you have intractable double vision. You'd walk around and you wouldn't be able to see because you'd see two images. If the eyes cross in a child, the brain suppresses the image, and then you never get development of that visual pathway in that particular eye. The eye may look anatomically perfectly normal and not be able to see. And it's something that the brain will suppress that image. It's a developmental characteristic that's probably a safety feature back in hundreds of years ago, where your life would be at risk if you had true double vision. Is that lion coming at me from over here? But in this age, it just causes a loss of vision, and it's a concern in kids. So it's important to get kids screened and get their vision checked, or if you notice something in a child early, to get them to an appropriate eye care professional to actually figure out, is this something that we need to treat? Do we need to patch the good eye, make the bad eye see a little bit, and develop those pathways? It's really remarkable how quickly those pathways can develop, and also how quickly they can deteriorate.
Wow. Now, just can we take a little break for a second? I'm practicing sitting up correctly, and it's doing a number on my neck. So, and also, I have a feeling, and it doesn't mean it's happening, but a feeling that my nose was running. Anyway, so all this will be edited out. And another is, give me a moment to find out where we are. Yes.
Nope.
Back on. Okay. This other issue is one that a couple of questions to pose. In cataract surgery, you can either do it with a scalpel or with a laser.
Yes and no.
Okay.
Yeah.
Well, would you speak on that? When is laser treatment called for? It's got to be more
Almost
common.
never.
Okay.
So we use lasers in cataract surgery. Laser cataract surgery, or what we call femtosecond laser, is really a misnomer. It really is a laser, I think, that was looking for a home. I think industry was looking for a place to use this laser. It was something that was used to cut a flap during LASIK refractive surgery. It would actually cut the flap on the cornea very precisely. And I think some people got together and said, well, it's a very limited use. Can we find a use for this laser somewhere else? Well, why don't we try to do something with cataract surgery? It never seemed to make a lot of sense for me, and there are certainly some surgeons out there that use it as part of their cataract surgery, but it's only a part and parcel of cataract surgery. Cataract surgery is the removal of your natural lens with a replacement, typically, of an artificial intraocular lens. And what I like to tell my patients is the most of the decisions that are going to lead to a successful surgery are done well before we set foot in the operating room. Our preoperative measurements, our preoperative discussion, what are our expectations of surgery, are those realistic? And setting reasonable, realistic goals and having a plan ahead of surgery. The most important part of your outcome is not going to be whether your cataract was taken out with a laser, an ultrasound, which is typically standard of care, or whether we used a knife and fork. Do you see the way you expected to see? And most of that has to do with how accurate we were, how good our measurements were, how good our procedures are in terms of delivering a good outcome. And how good is the surgical team that works with the surgeon, because it's all part of a team to make it a great experience. We use, femto laser can be used for small portions of cataract surgery. It can be used to make an incision. It can be used to make little incisions in the cornea, which is the clear window of your eye, if you're dealing with astigmatism and you want to make some astigmatism correction. Although my argument would be, if you need astigmatism correction, you're actually better off doing it with an intraocular lens, which has it built into it. It's a much better way to do it. For small amounts of astigmatism, we can make small microscopic incisions with a diamond blade, and typically they've been shown to be more effective, at least as effective or more effective than the laser. The other part of cataract surgery that can be done with the laser is what we call the capsulotomy or capsulorhexis. When you take out a cataract, imagine you had
What is that?
So it's basically the opening in the front of a lens. So when we take out your cataract, which is, picture an M&M. That's almost the shape of your natural lens. It looks like an M&M. So imagine if we opened up the shell, the front shell of it, and we took out all the chocolate on the inside. that would be how we take out a cataract. We like to leave the outer shell, but you have to open the front of the shell. Usually we do that with a little instrument, and we actually make a little round opening that's very strong, and it keeps the capsule intact. So when this capsule is clear, we scoop out all the chocolate, and then we put your new lens inside that capsule. And it's suspended within your eye, and it's got little springs on it that hold the lens in place. It's fascinating. And that lens is fit really to your needs. So if you said, I want distance vision or near vision, or you want astigmatism corrected, which is where your eye is shaped more like a football than a basketball, or you want to have a lens that gives you distance and near, which is what we call a multifocal. So there's a lot of choices out there today, and really the most important thing is mixing or fitting that choice and what you're looking for, making sure that's a correct fit. Certain lenses are just not good fits for individuals. Mm-hmm. So back to the laser, it can make that little opening, but again, we can make that opening with a little forceps, and it can also divide the lens with the laser. But the actual lens pieces have to be removed with an ultrasound, and that's called phacoemulsification. I will tell you that the laser costs more money. It's not covered by insurance, and the only time you can actually use it on a patient and allow them to pay for it is if you're correcting astigmatism. Because I told you there's better ways to correct astigmatism than using the laser from the femto. Put the lens in with the astigmatism is a better way to go. The actual lens, so when we make the little opening in the front of the lens, and this is a very critical difference between the two procedures versus tearing. When you tear the opening, it's continuous, and so it's very strong. I would equate that to when you open up a new bottle of ketchup and you've got that little perforation and you have a hard time, you try to take the plastic off the top of it, you could stretch that plastic and pull it, and it just won't go, and then you put a little nick in it, it just splits. That's the same thing when you talk about what we call a capsulorhexis, which is the tear, versus the laser. The laser actually makes the opening in the lens, and while it looks very much like the round, perfect tear, it actually is made with micro punctures. So it's actually like a serrated edge. If you look at it under an electron microscope, it actually loses strength. So when we go in to take out your cataract, we're pulling on that capsule. It's getting pushed and stretched. And what they've shown is that it's 3 times more likely to tear and rupture the capsule because the laser, while it looks like it's a continuous circle, is very micro tears. And so you have all these micro tears that take the tensile strength down on the capsule. So,
by the way, that's exactly how materials are processed with lasers. Mm-hmm. A series of shots that make
right. So you don't have a continuous strong. So as I said, I would equate that to trying to take the plastic off the top of a bottle. You put a little nick in it with a knife and the thing just splits. And that's what happens with these capsules. That's why they've shown 3 times more complications with the laser cataract surgery versus our regular. And the other part of it is it takes much longer to do. So it's more costly, takes longer, and it has more complications. And that's why I tell patients I find zero benefit to that. At least in my practice, in my hands, cataract surgery is a very safe, very predictable procedure. And we try to make it as safe as possible. And obviously, there are things that can go wrong, and we know statistically what those things are. We don't want to introduce something that really, to me, is more of a marketing tool than anything else. People like that. Hey, I had my cataract surgery done with a laser. Well, you really didn't. And if I were able to show you a video of the laser cataract surgery versus the way we do cataract surgery, which is the standard typically, patients would never choose to have the laser done.
Okay, but you did introduce LASIK, the vision correction.
Yes.
Now, that's, last time I knew it was around 30 million of those had been done worldwide. And can you comment on that? It seems like it's a cosmetic more than anything else.
Well, it definitely is. But there are certain professions that, if you're a law enforcement officer or you're a Marine or you have other things, you're a firefighter, where wearing glasses or corrective lenses, contact lenses could be dangerous to your actual well-being, it can be a necessity. LASIK was the second version of what we call, refractive surgery. Well, actually, more than that. It started with RK, radiokeratopathy.
Let's tell the audience LASIK is.
So LASIK is essentially a laser correction. So what I try to tell people from a lay term is basically we're carving your contact lens prescription or your glasses prescription into your cornea. The clear window of your eye is being reshaped to allow the light to focus in your retina. So when you have the corneal surface, so essentially started with RK where they actually made micro cuts in a radial fashion in the cornea. What it did was it actually flattened the cornea. So it made it weaker. And by flattening the cornea, you were able to decrease the power. So it was typically done to correct people who are nearsighted. And if you're a nearsighted person, essentially what happens is the light going through the front of your eye focuses in front of your retina. So the light focuses here and your retina is here. And by flattening the corneal surface, you allow that light to diverge. And you diverge it hopefully enough to meet right on the retina so that it's in focus. With LASIK, well, they went from RK to what we call PRK, which is radial keratotomy, which was the incisions with a diamond blade. Started in Russia with a guy named Fedorov.